All right, so we'll start with the first case. I guess you guys by now, just by looking at it, hopefully you will know what's going on. Okay, let's start with someone would like to discuss it. Dr. Rabia, can we start with you as you were the
Yes.
start with? All right, so
Yes.
So obviously it is a resection, and sometimes it is superficial. I'll tell you this is a salivary gland. I know I don't see much of salivary gland tissue, but this is a salivary gland, and sometimes we do superficial lobectomy, sometimes deep. It depends on where the lesion is. All right, so this is a resection, and we like to ink in the incision, and let's just make a small comment. You know what's going on here? Do you see this area here?
It looks like a dilated duct.
Yeah, so there is something which is not kind
It's a lopa,
there is some amorphous material.
amorphous material in the duct.
Yeah, it is like amorphous material, some granulation tissue here, maybe some granulomatous area, maybe there is hemosiderin, with lady macrophages with a chronic inflammation and fibrosis. There is lymphoid aggregate. What do you think what's going on? What's this? Like, why we are having these things here?
Looks like this grumous acellular material in a dilated duct, or it possibly, but I can't see any duct lining here.
That's correct. That's correct.
There's no duct lining.
Yes.
Yeah, it looks like I'm not sure what's happening here.
Yeah. So this is good. Actually, I'm trying to trick you here. Sorry that it is in the way that sometimes there are some artificial stuff. It may look like it is a lesion or this is part of the process, but it is like an artificial stuff. It is a consequence. So as I said, many times, and expect this to salivary gland and expect it in thyroid as well, because they are like, they're target to get fine needle respiration. Again, I'm biased because I'm a cytopathologist. So you can get like, changes, and sometimes, as Dr. Lavalsi mentioned it, as worrisome changes, especially in cytology, that as a consequence of fine needle respiration. So probably this is fine needle respiration being bunked and making this, and sometimes salivary gland, especially the oncocytic lesions, they love to have, or they after
I think the microphones of the attendee needs to be muted. As there are some people, they are complaining that they can't hear anything.
Okay, you too, Rabia, for a second. Can you hear me, guys, now? So we said that there is a problem. We have that the fine needle aspiration findings can affect the lesion. So be careful about this, especially when we see hemosiderin-laden macrophages like here, when you see chronic inflammation, we see fibrosis, when you see cholesterol clefts. This is what we call cholesterol cleft. So this is probably the lesion being finally aspirated before. Okay, all right. So overall, it looks kind of well circumscribed lesion, and which is in salivary gland, it's not that much of helpful, meaning that we know that benign tumors are well circumscribed, but it is not a rule here. We see even malignant tumor are well circumscribed. However, when you see a very invasive, tumor, irregular tumor, don't jump to the conclusion that it is benign. Okay, try your best to really see what's going on, and this could be malignant. Okay, so well circumscription is We see it in benign and malignant, but very infiltrative lesions, we kind of more suspicious of being malignant. This is from the low power. Start with low power. Okay. Always keep an eye on the inked margin, even before knowing what is the lesion is. Try your best to see, okay, there is a focal involvement, or it is well circumscribed, there is a capsule or not. This will help you as well, because many benign lesions, including this, you would like to comment on the margin, even it is benign. So this is a kind of unique for salivary gland lesions. Okay, all right. So we see here it is kind of all right, kind of capsulated. There is very close area to the ink. That's fine. And when we go to high power, can somebody give us a kind of buzzword of what's going on here? How we'd like to describe this? You know, this picture. It is like, you know, what is the nature of this tumor? Like, this tumor is, what is the component of this tumor? I'll look into the chat area. Well, I see mixed. I agree with that. Do you have a fancier word for it? Well, I like kind of biphasic. Triphasic is a genius word, but let's go with biphasic, as we usually like to, you know, describe lesions either to be one component, as I said, biphasic. It is like epithelial, or I mean monophasic, just epithelial, or mesenchymal. This is monophasic, or biphasic, meaning that it has both of the two words of the epithelial component and of the mesenchymal component. Okay, the background we see here. What is the word that you like to use here in the background? What is the background secretion here? The background is, I hope you guys don't use mucin, and this is actually from both. For both, the mucin, if you use a mucin in salivary gland, you are going toward a bad diagnosis, and sometimes surgeons, they will be confused. If you see a mucin, so you're dealing with mucoepidermoid carcinoma. Okay, so we'd like to use the word that you said, myxoid or chondromyxoid. Both of them are fantastic, and you'll see some areas that it is kind of bluish hue with the mix of some cells here. These are the myoepithelial cells, and this is like chondroid. And actually, you should see that from the gross examination. While you are grossing it, just 2 days ago, I got frozen, and once they cut it, I asked the resident, so what's your diagnosis, or your differential diagnosis, on top of your differential diagnosis? And he told me, oh, there's myxoid area, thinking of pleomorphic adenoma. Okay, so that is how we go to this. The other component is the ductal area, and also the myoepithelial area. Okay, so these are the two usually component of this lesion. So I'm sure by now everybody get to the diagnosis. This is a pleomorphic adenoma, and or the other word is benign mixed tumor. Benign mixed tumor based on the component that it's there. Okay, so I think this is like an easy diagnosis. Everybody has species cytology. Then we go to the, you know, the histopathology. It's easier to grasp. Boom. Well, don't just, you know, do that. Just don't just give pleomorphic adenoma, period. Try again. We check the marked inked areas, if it is, you know, if it is clean or not. And the reason is, pleomorphic adenoma has a tendency to make something called a, anybody knows what's going on? What is the thing that it is like, there is a bulge here? Any word? Yes, excellent. Yeah, pseudopodia. So pseudopodia meaning that it usually doesn't love to just be a circumscribed like an orange. No, it loves to do some pseudopodia, like, you know, goes around. And as we know, our, you know, histopathology is two-dimensional, and the reality lesions are 3-dimensional. So if somebody has like a superficial cut, we miss this area, and sometimes it will go throughout the ink and the margin will be positive. And the problem is here, what is the significance? Significance is there is a tendency by this, pseudopodia to have recurrence. Excellent. So it will be a recurrence. And that time when it is when the specimen or the pleomorphic adenoma recur, it is very nasty. The whole neck will be like creeping with this myxoid material, and it will be almost impossible to get a clean margin after that. So it is one shot. It's your first shot to have a clean margin. And I've seen cases, patients lie being miserable here in our hospital. Some patients lie being miserable because it was cut not appropriately from the first time, and the patient has extensive recurrence, and they don't really like, I see some surgeons from other local hospitals. They come to our medical center, University Medical Center, and seek expert opinion for this case. Even it is like it's benign, but it is discussed in the tumor boards. It's been like, they brought the best surgeons to try to manage it, and the result still is not great. Okay, so this is one reason that try your best while you are, grossing it, ink the specimen, really give the gross description, cut it well. So don't just make a cut in the middle and just throw it. No, do your best part to give them this answer. Okay. The other reason that we don't like to see some pleomorphic adenoma in the body, anybody knows what is the other significant reason of pleomorphic adenoma that it may make problems after a while, or why actually, some people, our surgeon, they would like to take it away, is exactly as Ali and Mariam said, there is a tendency to malignant transformation. Okay, malignant transformation. Anybody knows how much the risk for that malignant transformation? Around how many percentage? Yes, yeah, around 5%. In real life, I mean, some people say 5 to 10%. And I always hear that, oh, this is a high, like, a high percentage. But, pleomorphic adenoma is very common. So if you keep a lot of people with a lot of pleomorphic adenoma, probably will be some changes. So basically, in the exam, they will tell you that this patient is elder patient, has this, mass in his salivary or her salivary gland for a while, and then all of a sudden start to enlarge. Okay. And there will be another cancer. I mean, will be arising from a cancer, carcinoma XPA, and you have to thoroughly examine it. And it is a carcinoma. It's not something that you'll see, oh, there's some atypia or some. No, there will be a real changes as a cancer. Don't just, we don't take it. You don't take it like, if somebody is convinced it is cancer, if somebody else is not convinced, no, everybody will be, yes, this is a cancer, real cancer. There is huge changes, there are metastases, there's a lot of necrosis. No, this is a cancer, and we see in the background pleomorphic adenoma. Okay, so these are basically the important clinical parts that you have to address during. You give the size of the tumor, you give the margins, and you give the diagnosis. Okay. And usually we don't do immunostains, like, this is a morphological diagnosis, and most of the time you just go with the H&E stain, that's it. However, sometimes you do some immunostains, and when it is special and fine aspirations, and the descriptions say that sometimes the pleomorphic adenoma is very cellular, and sometimes it's myxoid. So it is, either way. The cellular part, it is the tricky one. Okay, especially on finding the aspiration. So we will do some stains, and we'll go with that, Hannah, with the case of pleomorphic XPA, on how to measure the invasion. Okay, so just we'll check into that later on. So the stains, as somebody discussed, it is the EMA, GFAP, S100. We can do P63, cytokine seal positive. It's not that helpful, actually. It's not something that will give you the magic answer. Basically, salivary gland tumors, they have kind of similar component. It's just the arrangement is different. Some, like, you know, if you go to the actinic cell or the adenoid cystic, you'll find some similarities in the immunostain because the material, the component are similar. Okay, myoepithelial cells, some ductal cells, some, you know, stromal cells. So the architecture is more important. But there is kind of it is molecular signature. If anybody, excellent, Miriam. This is the BLAG1. Okay, pleomorphic adenoma, gene 1 or HMGA2 rearrangement. It is very important, and it is around. We see it around 70% of the time. 70% of the time we see this rearrangement. Okay, so it can be helpful. I know that, like, you know, some big places like in the Mass General Hospital, Johns Hopkins, you will see especially Dr. Paquin, Bill Paquin. He very interested in molecular testing, and you will find some cells, you will, you know, very nice immune stain being done. You can do that. BLAG1, it can be done by immune stain, but also with FISH, rearrangement can be done as a signature. Okay, and you know, sometimes it's just for exercise, as academic exercise to do that, but it's good. So to recap, as we know, salivary pleomorphic adenoma is the most common salivary gland neoplasm. It accounts roughly around 80% of salivary gland neoplasm, and usually occur in big, you know, salivary gland. It's like, you know, major salivary glands. The tumor is a parotid species, the parotid. Okay, and wide range of age, and can have. It's also common in children. A little bit more in female, but it's not that much difference. As again, superficial lobe of the parotid gland is the most common plate. It can happen even in minor salivary gland. I've seen it in the tongue, I've seen it in the lip, I've seen it in different places, and people, they would come mostly for discomfort from cosmetic reasons. They would like to do this, you know, you do finite aspiration, and you do most of the time superficial parotidectomy to save the facial nerve. We don't want to, you know, do a radical. So that's why it is important to know it by finite aspiration. You know exactly what is the component or the description or the, you know, the morphological features in finite aspiration, and also want to take it off besides cosmetically, because the patient may have the chance, especially if it is very long, like more than 15 years, this lesion being there, or been multiple recurrence, or patient is old, like getting to the older side of 40, and male gender. The size, again, we put the size in the report, so it is more than 2 cm. And if it is affecting not only the superficial lobe, or it's affecting basically the deep lobe, try to actually, and being sudden changes. So patient with these risks probably will be having the carcinoma changes, so transformation or malignant transformation. Okay. The good news that radiology is fantastic. You can go first with the radiological features. They will tell you this, you know, this density probably it is a pleomorphic adenoma, and there are areas, or there are no areas or problems or any transformation. So they'll give you that, you know, that description first, and you can go, and most of the time we don't do immune stains. Just, you know, be thorough with your examination. Okay, all right. So I think we covered this first entity. It's very important. It's common. So expect anything in the exam to ask you about pleomorphic adenoma. All right. Good job, everyone. Let's go with the next case. All right. So I'm gonna try to, you know, go with the low power first. This is an area of, it is actually minor salivary gland, sinonasal area near to the ethmoid area. And you see here, there is a part of the eye. This is the eye. This is the optic nerve. Unfortunately, this is like exaggeration. And the lesion is creeping toward the skull, or toward the brain. Okay, so it is bad from the beginning that while they are doing this radical resection, it looks like a bad tumor. So when we be giving some slides, try to assess where you are first and try to assess the situation and how they are creeping into what are the vital structure surrounding them. Okay, all right, so let's see here. In low power, anybody can show the diagnosis, and then we will be describing if any differential diagnosis. Yeah, excellent. I see most of you got it. Good. This is adenoid cystic carcinoma. Again, this is like, the things that you look into them and you know them. All right. So adenoid cystic carcinoma. There are also some important things that you have to put in your diagnosis, and they will ask for it. First of all, they will ask you the grade. Okay, so grading is very important. This is the real. They will ask you the margin. Okay, and obviously here, ink margin is positive. Okay, and they will ask you, excellent, they will ask you about perineural invasion. As I can just shoot into it, even from low power, this is a perineural invasion. The usually perineural invasions, sometimes it's a little bit tricky, especially in the core biopsies. And we get a lot of these core biopsies first, and we don't have a lot of real estate to examine it. So that's why. So try to find perineural invasion at the periphery, like here, at the periphery of the lesion. You see perineural invasion here. Okay. So shoot at the periphery of the lesion, go around it, check. Usually they love to have perineural invasion around the lesion. The other thing you have to put in your diagnosis, the percentage, which is something I do, the percentage of the solid component. Perineural invasion, adenoid cystic carcinoma, it can be difficult to assess the grade because it's a little different than the other, adenocarcinoma. It's not actually, it is adenoid cystic carcinoma. It looks like it's an adenocarcinoma by definition, but it's kind of different, different criteria, and you have to know these criteria, or at least be familiar with the criteria for differentiation or grading the adenoid cystic carcinoma. Basically, you have to tell them either low grade or high grade. Okay, and the most important component to give them this is the amount of solid areas. Maybe you'll find some areas solid, kind of solid like this. It is overall, if it's less than 30%, 30%, that's fine. You're still at the low grade. Okay. Other parameters are like, necrosis, the tibia, the mitosis, how the tumor look like, and you will see if it is very ugly. You will go. It is not like the grading system. It's not universal. Like you won't see everybody is using. Like, it's not like Nottingham for breast or no. It is something, or Gleason scoring for prostate. Everybody is kind of using it subjectively, but overall kind of comment on the solid area nonetheless. Okay, how many solid areas? And I even was asked by radiation oncologists to comment not only on perineural invasion, but also the caliber of the nerve. Like, some of them, they want how big is this nerve and how many foci it has perineural invasion, and even to comment on intraneural invasion. Sometimes we see perineural, what we see is perineural invasion, but many times we see also intraneural invasion. Okay, so this will give them some clue how far they're gonna do with their nerve. Yeah, just use the regular measurement from your microscope. There is like we have a lens specific eyepiece to measure the nerve. Again, this is like pushing it too far, and again, you won't find everybody's using that, but expect that because we expect you to get the best of what we got. All right. Okay, so while discussing it, again, it is from the name. Does anybody know why we don't say adenocarcinoma, we say adenoid? Is there any reason? What is the difference? You guys are kind of, well, why we don't say adenocarcinoma, we say adenoid? Excellent. Excellent. So these lumens that we see them here, they're not really duct of adenocarcinoma that they acini. They are just pseudolumens. They are not a real lumens. There won't be a secretion in, into them. There will be no real secretion. And actually, they hold a lot of basal layers that are P63 positive. And we know that adenoid cystic carcinoma can be in salivary gland, can be in breast, can be in any other areas. Okay. Okay, Dr. Tranesh is shooting us with the answers. We will go into that in 1 second, Dr. Tranesh. They are not really lumens. So there we saw adenoid cystic. Okay, and these cystic spaces within with tumor. So technically, we don't see real cyst like a big cyst as we see it in, for example, mucoepidermoid carcinoma, and this is important. Like if you have major cysts component, it's kind of against adenoid cystic carcinoma. Okay, even there is adenoid cystic, the cystic part. Cystic part, it's not like making a big cyst; it's just making these small cysts here and there. Okay, all right. So we see some matrix proliferation, some metrical stroma cells, which is kind of differential diagnosis for lesions like cellular pleomorphic adenoma. So keep in mind cellular pleomorphic adenoma and adenoid cystic carcinoma. So overall, there is the solid area, the trabecular cribriform, which is also common that we see here, the cribriform differentiation or the growth pattern. It is cribriform. Okay, all right. So let's go now to immunostains that we can do. Again, it is kind of non-specific. It's not something that regular immunostain will give you, but anybody know what kind of immunostain would like to order? Yep. Yes, the percentage of solid, we usually, we say 30%. If it is more 30%, we describe, again, the other component, but this is what we usually matter. Immunostains, excellent. We see P40, P63, c-KIT. And what is the importance of c-KIT? I see a lot of you know that c-KIT is important. So if we have c-KIT positive, does that make it adenoid cystic carcinoma? Yes or no? Excellent. Excellent. Yes. All right. So if c-KIT negative, c-KIT is negative, does that make it not adenoid cystic carcinoma? The answer is unlikely to be. Unlikely to be adenoid cystic carcinoma. Okay, so it's a little bit tricky. So adenoid cystic carcinoma is usually c-KIT positive. Other tumors are not c-KIT positive. Other salivary gland, they should not be c-KIT positive. However, that doesn't make it adenoid cystic carcinoma. We still have some other tumors, salivary gland tumors, that are c-KIT positive. Okay, but having a small, especially in core biopsy, I'm talking about it because most of what I do is small core biopsies. That's what I get, and most of the time even final desperation. So you have to get ready to explore tumors that are very tiny. Okay, especially for these days, the minimal invasive procedure are the most important ones. Okay. So when you have a lot of plenty of tissue, you can do whatever you like to do. But we have a small fragments of tissue, we really want to reserve it. So again, if you have c-KIT positive, c-KIT negative tumor, it is unlikely to be adenoid cystic carcinoma. Okay. What is the next step you can do? What is the immunostain? Actually, there is immunostain. I saw it being described, but you can order it as immunostain or FISH, which is excellent. The MYB, the MIB, immunostain, NFIB1, FIB gene fusion. If you'd like to do FISH, this is it is not a crazy specific. You can still see that in some lesions, but it is it is more than 80%. I mean, it's not that crazy sensitive. Like it's not 100%. It is 80% of the time. So if it is negative, it could be still not adenoid-cystic carcinoma. It's positive. That's mostly okay. Okay, so 80% of the time, adenoid-cystic carcinoma will be positive for MIB. Okay, MIB NF1BG. Okay. So let's recap for adenoid-cystic carcinoma. You have, it is usually loves to be in minor salivary glands, and it is like, the most common minor salivary gland tumor. Okay, it's not just the most common salivary gland, it is minor salivary gland tumor. Okay, overall it is the fourth most common salivary gland tumor overall, and usually it is in elder. We don't see it much in young, and it can be in everywhere actually. It's not just head and neck area, meaning that it's not just oral cavity, or it is can be seen in lung, can be seen in sinonasal areas like this case. It can be whenever there is minor salivary gland, it can arise and make. And I've seen it in lung, breasts, all the upper GI, upper aerodigestive system actually. Okay. The important thing is to describe lacrimal gland 2. Describe the tumor, margins, perineal invasion, extension, the grade of the tumor, and be sure that you are dealing with this tumor where the margins and the grading is as your best you can describe. Usually when it is high grade, it will be like a lot of mitosis, a lot of necrosis, very invasive, and all the other other changes that we see in high grade. Okay, so these are, and the other problem that it may have this skip lesions, like here sometimes we've seen, and I've seen it in some areas, that this is salivary gland tumor, and you'll find again area of tumor here, so it skips. All right, now a question which is the AJCC 8th edition being emphasizing on, it is the parenchymal invasion. Do you guys think there is parenchymal invasion here? Imagine that we are dealing with salivary gland, major salivary gland. There is, you see the fat here? Do you think this is a parenchymal invasion? Okay, let's go with Aman's question first. Differentiation between primary breast adenoid-cystic carcinoma and salivary gland. Actually, it is not easy even with other carcinomas. Breast and salivary gland, they have kind of similar embryology, so it's not an easy thing to differentiate. Maybe even lung sometimes, because this tumor is TTF1 negative. Okay, so it's not an easy task. So, but also it is likely if there is a breast mass to be coming from salivary gland. Okay, so usually we don't have this problem in our practice, in daily practice. Theoretically, yeah, it can happen when it is salivary gland going everywhere, but usually you will see a lot of the problem actually with adenoid cystic is yes, it gives metastasis. I just get a patient with I've seen a patient is 38-year-old and has this metastasis to the lung, but the major problem is the perineural invasion, that it creeps with the nerve till it gets to the spinal nerves, and it goes to cranial nerves, and it will go to the brain. This is the real problem. Patient eventually die from this disease after a while, after like sometimes 10, 15, 20 years, eventually they're gonna die. Okay, so going back to my question, that I want some answers other than Hina. So do you guys think this is a parenchymal invasion or not? Having that this is a salivary gland, and we see the fat here going, like the tumor going beyond the fat, or going through into the fat. And it's okay, just speak your mind. If you don't answer, that's fine. I see a couple of yeses. Good. Any other, just to make it a, all right. So 3 yeses and 1 no, 2 no's and 3 yeses, and 3 no's. Okay. All right. So there is the mix now. It is like 50-50%. And the answer is no. No. To say in your report there is extra parenchymal extension, you have to define that by either 2 ways, either radiologically or gross examination. You cannot define that by microscopic examination. And the reason is fat is kind of the component of salivary gland. So if you have a salivary gland, parotid salivary gland, and you'll find the fat inside the salivary gland. It is part of it. It's not like you're dealing with pancreas or prostate where fat is not part of it. So if you have glands in the fat surrounding the prostate, that is not normal. That is adenocarcinoma, even if they look very well differentiated. Okay, the same thing for prostate. Beyond that capsule or pseudocapsule, you find tumor in the fat that is not normal. Here, you cannot define except by radiological examination that they say radiology, oh, there is, it is out beyond the gland, or gross examination, you see that grossly. But if you find tumor in the fat in salivary gland, that doesn't make extra parenchymal extension. Okay. Any question about adenoid cystic carcinoma that I didn't cover? Yeah, radiology and gross. Radiology and gross examination. Radiology and gross examination. Basically, you'll see like tumor is going beyond the limit of the normal boundaries of that salivary gland. Okay, so that make it extra parenchymal extension, but not just finding tumor in the fat. All right. Okay, sounds good. Basaloid squamous cell carcinoma. Very excellent question. Very, very excellent question. That is one of the occasions that we do, and we do immune stains for that. First of all, basaloid, you will see the palisading. It's not like something, but let's say the solid variant of adenoid cystic carcinoma versus the basaloid squamous cell carcinoma based on core needle biopsy. Okay, so my experience, many times, what will happen, there will be a oropharyngeal carcinoma, and oropharyngeal carcinoma it is like, the HPV type. It will be giving metastasis to a lymph node, and that we see it in 85% of the times. Okay, like patient doesn't have any symptoms, but she has a neck mass or just a lump, and they will be giving metastasis to a lymph node inside the salivary gland, and this lymph node will be expanded and will be outgrown by this squamous cell carcinoma, meaning that the whole tumor will be, growing outside that lymph node and going into the fat, and you'll find you really don't see lymph node anymore because it's been outgrown by this squamous cell carcinoma. And look, of course, basaloid with all necrosis. And first of all, they won't be that much of similarity, meaning that they tend to have more necrosis and very, very dark, very high NC ratio cells. Okay. The other thing, if there is no way by histologic examination between the solid adenoid cystic high grade and basaloid cystic carcinoma, you can do first of all the HPV. The HPV will be helpful for basaloid. It will be positive. B40 usually positive, but it can be also positive in adenoid cystic carcinoma. You can do the CCAT, and usually CCAT will be positive in adenoid cystic carcinoma and negative in basaloid squamous cell carcinoma, meaning that we are talking about the basaloid or talking about the basaloid variant of squamous cell carcinoma, sometimes both. Okay. If everything is negative, sometimes it's not easy answer. You have to do the MEB, you have to do like other markers, and sometimes you just say basaloid carcinoma and give differential diagnosis. Just basaloid carcinoma, and this is my differential diagnosis, and give it to the clinician to see if there is oropharyngeal carcinoma. Basal cell carcinoma usually not. It starts with the skin, and it is not that much of difficult, so you can do that. But it's a very good and common question, and but you do your everything, your homework. If you can differentiate, if you cannot, you cannot. That is not something that we are always able to do. Okay, very good. Let's go with the next one. And okay, so in one word, well, yes or no, well circumscribed or not well circumscribed, or ill circumscribed if you'd like to use. Yes or no? Excellent. So this is a well circumscribed lesion. And we say that benign lesion will usually well circumscribed, but also malignant low-grade lesion can be well circumscribed. If you see it ill-defined, that is good. You're kind of looking for, but just build your usually if you see this, I'm dealing with benign versus low-grade. This is usually the salivary gland, and basically they kind of sum both the benign / low-grade tumor, malignant tumor, in one category, and they put the high-grade carcinoma in another category. The difference that surgery, it is just simple resection for benign / low-grade, or radical resection with neck dissection, and they will be sacrificing the facial nerve. So don't kill yourself that much between benign and low-grade malignant, but really kill yourself between benign, low-grade versus high-grade. Okay, because that really matters for them, and they will, really want to be sure that they're not dealing with high-grade. So, all right. So it is well circumscribed tumor. Kind of looks like, homogeneous. Yeah, like cells, they look alike. It's not much of difference. So we'll go just in one area here. Anybody would like to give any subscription? Yeah, there's thin capsule. I agree with that. So okay, when you have cells like that, it is monophasic, I guess. Kind of solid versus, well, we have some spaces here, so I would go with acinar, maybe, cystic areas. I agree with that. What is the cells themselves like? Are they pleomorphic or monomorphic? Yes. So I don't see much of pleomorphism. It's kind of, they look alike. Okay, good. I don't see mitosis, necrosis. They look all similar. I see some material in these spaces. It is pinkish. So when you see pinkish material, what do you think? Yeah, that is a good one. Usually it is proteinaceous material. So usually the protein, including the milk, because they like, when you see it under H&E, it is pinkish. Okay, so when you have pinkish, usually proteinaceous material, secretory material. Okay, it is not that much of significant, but it's good to know that, okay, this is not like, this material is not like, for example, other secretion that may be specific for other lesions. Okay, for example, like alpha fetoprotein material, and like in germ cell tumors and extra. I don't want to discuss that. All right, I see that most of you guys go with secretion. I agree, and this is secretory carcinoma. Anyone would like to comment? What is the diagnosis? If we are in 2009 right now, we are in a group here, and this is 2009 or 2010, and I give you this lesion. What's your diagnosis would be? Excellent. So the diagnosis would be, I want somebody actually more specific in this. I agree with Chris. It is actinic cell carcinoma. I agree with you. Can you give me more kind of 2 words or 3 words more of that diagnosis? Dua, it is not masked yet. So they will call it actinic cell carcinoma, but they will add zymogen bore. Okay, zymogen bore actinic cell carcinoma. Excellent. That's the diagnosis. I don't blame them because they look like secretion, and that's what the diagnosis have there. All right. let's say we are 2015, or let's say actually 2014. What's your diagnosis now? It will be a memory analog secretory carcinoma. Excellent. Memory analog secretory carcinoma. It's based on a very nice paper describing it. I think it is from UPMC, University of Pittsburgh. I'm not 100% sure. Don't quote me on this. So they call it memory analog because it has the secretion, looks like, you know, the tumors that we see in them. And basically, the person or pathologist who worked on this, she does a lot of breast tumors, and she found that, okay, there is this breast tumor that I diagnose, and it's similar to the breast tumor I diagnosed in the head and neck, so she call it memory analog. Okay. And now, yes, Rabia, the diagnosis is secretory carcinoma, and you put salivary gland. Okay, so secretory carcinoma, actually they found that secretory carcinoma are more common in salivary gland than breast. So some people, they say in the breast, they would like to call it salivary gland analog secretory carcinoma. It's like reversing, you know, the magic. But it is just you know, crazy things that people they do. Pathologists are crazy sometimes. So this is what they call secretory carcinoma. All right, good. So secretory carcinoma, the importance that to see that it is not a sinus cell carcinoma. One thing to say, again, it is well circumscribed, but it is malignant nonetheless. So be careful with that. All right, so what is the immune stain you'd like to order to say this is not a sinus cell carcinoma? All right, Mariam, you got it. You are the winner. Mariam got it. It is DOG1. DOG1 should be negative. Okay, DOG1 should be negative. What are other immune stains? Would like to order, you order S100, which is the most important one, by the way. Most important one is S100. The other stain is mammoglobin. Okay, mammoglobin. You can order the PRST2 or the GCDFP1. That's good. But these are the, you know, you would like to order the mammoglobin. By the way, after the double M, there is A, not mammoglobin. So you will do your immunostain, you do the DOG1, you do the S100, you do the mammoglobin, and I would love actually to do c-kit with that because I would like to see, you know, also making differential diagnosis of adenoid cystic carcinoma. Okay, especially the cribriform. Again, I deal with most of these are needle biopsies, core biopsy. Rarely I get like, I mean, to start with your diagnosis with this resection. Usually they will find it aspirated case first. All right, very good, very good. Okay, let's go now with the genetics. I saw some people, they answered it already, but the gene translocation or the fusion gene is the ETV6 in TREC3. Okay, ETV6 in TREC3. Okay, let me make it more difficult for you. In my board exam, in my cytopathology American board exam, they asked me about this, but they didn't ask me about which the ETV6. They give me what is translocation. So it was very mean question. Okay, sometimes they'll ask you about the gene fusion, which is ETV6 in TREC3, but you have to know also the translocation, the chromosomal translocation between, it is translocation 12 and 15. Excellent. 12 and 15, the short arm 1-3, and the long arm 2-5. All right. Again, if you answer this, meaning that you are really high in your study, and probably you won't fail the exam, but just something that to keep in mind. Okay. All right, so it's good. Let's recap about memory analog salivary gland carcinoma, or what we call it right now. I'm sorry, I did my training in the area of the mask memory analog, so it still comes, sometimes it's stuck with me about the memory analog till actually what I do, to be honest, I put secretory carcinoma open parenthesis memory analog secretory carcinoma, And that basically it is a message for the surgeon. You can't give them a lot of nomenclature very fast. They will be confused. If I just make it secretory carcinoma, they will be going and checking, oh, is this like a mucinous carcinoma? They think that it is mucinous carcinoma, or sometimes metastasis from colon, believe me or not. So basically, I'm feeding them, spoon feeding, giving, okay, secretory, okay, so the WHO will be happy with me, and between parentheses, memory analog secretory carcinoma. So we'll see, oh, this is mask, good, that's it. Their brain will be happy, and they will be arranging the cancer. And they will be happy because it is low grade. Okay, so it is usually low grade cancer. There won't be problem with them resecting it as they did. Just give them the margin. Of course, you have to see if there's any transformation, as any cancer, it may transform. So be careful that you're not missing any of that. Okay, so it is not that common, to be honest. It is uncommon lesion, can happen at wide range, from teenager till 8-year-old, slow growing painless mass. Painless because we don't see as much of perineural invasion, and this is actually forgot to discuss it. Usually, if the patient come with tender mass, painful mass in the salivary gland, you will think of which tumor? You can write if you know. Yes, adenoid cystic carcinoma. Excellent. Let me. Excellent. Hannah, you answered my question that I'm about to ask, because the other differential diagnosis of painful salivary gland tumor is actinic cell carcinoma, and I want you to answer me why. Excellent. So actinic cell carcinoma has tons of zymogen granules, and with the trauma manipulation, these zymogen granules will be released into the pancreatic tissue, that salivary gland tissue. It has a lot of fat, and this zymogen granule will be doing fat necrosis, and patient will be having pain. It is vague pain, tender pain. It's not like perineural invasion. So that is in differential diagnosis. Excellent. So again, you will do your homework with these lesions. You look for necrosis, mitosis for any of these areas, and try to be descriptive and do some immunostains that we discussed. And rarely you will do, if it is very unusual or not comfortable diagnosis, you do the transformation gene. Usually you will send it to a bigger institution to do it for you, or consultation to other places, but most probably, again, you don't have to do that. It is good with the S100 dog negative and morphological. Okay. All right. I think we can have one more for now. Maybe we'll make a different session later on with other session, if you guys are okay. All right, so let's see here again the question. Actually, my question, which is, what is the organ here? Can anybody give me the organ? If you see, again, I am freak. I'm low grade freak, meaning that before going high grade, really give it a time for low grade. Okay. So, and sometimes low grade will be very helpful to give you the impression. Mariam, you said submandibular gland. Can you, why it is sub? No, before talking about the lesion, just give me what salivary gland. This is a salivary gland. I agree with you, salivary gland. But do you think this is okay? All right. So I think there are 2 or 3 answers about it is a parotid or it is submandibular gland. The difference, as you know, that when it is here, like here, we have what type of salivary gland tissue here? So you guys see mixed? I don't see mixed. I don't know. I don't see mixed. All right. Maybe you're looking at these. These are not salivary gland lesions. These are not salivary. It's not acinar. I mean, it's not like, you know, they're not the one that they secrete. They are ducts. Okay. So don't include ducts while you're discussing the type of acinar. Okay. So it is mostly serous. Excellent, Rabia. It is serous. Okay. When it is serous, and you have the R in parotid, so you have the R in serous. Parotid, serous. Parotid, serous. Okay. So this is parotid. If you have sublingual, it is mucinous. Okay, sublingual, mucinous. Submandibular is mix between mucinous and serous. Okay, so the idea here, knowing the organ is very important, because sometimes one of the things that you have two patients and they mix up between the lesions. So this is the only way it can help. It's not like you have to do it routinely, but it can help knowing that what I'm dealing now, mucinous, serous, or mixed. Okay, so this is parotid gland. And this is the lesion. Now we go to the lesion. Well, circumscribed or not? Yes, it's very well circumscribed. Again, does that mean it can be helpful in this lesion, but again, it is not that, you know, you can have similar, especially if you are dealing with core needle biopsies. Okay, is it homogeneous or not? Like overall, they look alike. Huh? Yes. All right. So what is the color, pink or blue? Yes, excellent. So this is the things that you keep in mind. This is basiloid lesion, And let's see here. You see that cells, they don't have much of cytoplasm. They have kind of high NC ratio. They are in trabecular way. Anybody describe what's going on here on this line? What is happening at this line here? Excellent. There is a palisading. Excellent. So there is some palisading. Yeah, it is, you know, it is fibrovascular core, but there is palisading nonetheless around it. Okay, there is palisading. You go here or there. Palisading. Okay. Palisading. You see this? It's nice palisading. Okay. So what's your diagnosis based on what we discussed here? Okay. Are you guys comfortable? It is not basal cell adenocarcinoma based on what I tell you right now? Yes. So we have, you can tell me it is basiloid neoplasm based on what I told you right now. Okay. Now it is your day, it is your homework to go and check the entire capsule. Look for capsular invasion. Okay. Any capsular invasion, any vascular invasion, and you look for any perineural invasion, kind of, but it is important to do that fully. Don't just assume that this is basal cell adenoma next case. I would agree with you most of the time it is basal cell adenoma, and to define it, it's basal cell carcinoma, you need like to prove that. It's not an easy thing. Okay, you have to how many sections to may suggest this is a case exclude? Well, I would like to at least get the entire capsule. If it is huge, first of all, if it's huge, you have to be worried. If it is big, you can go around the capsule. You can the entire capsule of the entire lesion. Give it like slice the whole thing every 3 millimeter, and if you don't want to give 50 slides to that tendon, give them like a good 10 slides with the whole thing, and then go around and take with the capsule. Okay, so you'll be comfortable that the capsule is, and most of the time again it's small. Yeah, like the follicular lesion of the thyroid. Yes. Yeah, you will be convinced when you see that. Again, nuclear atypia and all the features that usually they differentiate between benign and malignant, here we don't have that. So we cannot say that it is adenoma versus carcinoma based on cytology. Okay. Again, if you you don't overkill by giving 50 sections. Focus on the capsule more. Okay. And it should be very comfortable with the capsular invasion. Like you'll see, there is really mushrooming and tissue surrounding it, not just an area here just going through. The caveat here that the area of the fine aspiration, they may give you pseudo invasion, capsular pseudo invasion. So you have to really be careful that you are dealing with the capsular invasion away from that area. You see a fibrosis, hemosiderin-laden macrophages, capsular disruption. Does it mean by default you are dealing with capsular invasion? No, that is a changes related to the fine aspiration. If it is worrisome, just describe that. You can say basal cell. You just say basiloid neoplasm. You say that you are favoring adenoma, but because of some areas looks like capsular invasion. Of course, you give them the margins are clear. Basically, if the margins are clear and you are comfortable with that, there's no other other worrisome features. Probably the surgeon will be happy with that, and they will put the patient for observation. Okay, they will see like, okay, let's give him 6 month MRI. That's enough for him. They won't go and do chemo or the other stuff. No, they will just keep the patient. They put an eye on the patient, which they should do actually for every salivary gland tumor. They just, even benign, they just don't let him just go and that's it. Okay. All right, let's go now with the most common question. Anybody know what is the most common question of the basal cell adenoma? They usually ask. Yeah, the genetic syndrome, and before that is the mutation, which is, yeah, Fatima will ask that very important question. This is the CTTNB1. Other words, it is the beta-catenin. So the immunostain you do is beta-catenin, and you want to see the nuclear staining for beta-catenin, nuclear transformation of beta-catenin. Okay. Basal cell adenoma in salivary gland is basal cell adenoma. In skin, we call it excellent. It is cylindroma, species the membranous, variant. So we have growth pattern, we have solid, we have trabecular, and we have membranous. Okay, membranous pattern. It is like a jigsaw puzzle-like, and similar to cylindroma of the skin. Excellent. All right, so let's recap what we got here. Usually we don't see matrix in basal cell adenoma. It's not that the ones that they give, but usually we see small basiloid cells, and usually it's an elder population than younger. Membranous part, we look for skin. Counterpart could be coming from skin. Simple excision, usually curative for the lesion. Again, we don't have to do this fancy. I mean, beta-catenin is fine if we have it, but for the the gene, the transformation fusion gene, which is CTNNP1 activation mutation for the gene, which is again mutation for CYLD16Q12, ubiquitin, that we see in the basal cell adenoma. The important question is to define it, basal cell adenoma versus basal cell adenocarcinoma, and this with thorough examination for the whole capsule, and check if there is any vascular invasion or perineural invasion. Okay, so that's basically the important points we see in basal cell adenoma. Okay, any question from what we discussed today? Hopefully I didn't overwhelm you guys with these, kind of tricks. Hopefully you'll be comfortable now. You're reading about it. You did great. Actually, I barely get any new information. You always, know it before I saying it. So good job. I'm very proud of you. and we hope we continue with that. Shoot me with any question if you have anything that we can discuss. Again, I'm not that the expert, but I try my best. So it is like, discussion, collegial discussion. Both of us, we get the best of it.